Good afternoon, everyone. My name is Rahul Gosain.
And I'm Rohit Gosain.
And we are Oncology Brothers. Today, we have the pleasure of having a renowned educator and a clinician, Dr. Erika Hamilton from the Sarah Cannon Research Institute. Dr. Hamilton, we hope to discuss practice-informing studies in HER2 positive and low HER2 patient population presented at the SABCS 2022. Dr. Hamilton, thank you so much for joining us today.
Thanks so much for having me. It's been a great meeting, and I'm happy to discuss this.
Welcome, Dr. Hamilton. As we continue to see these paradigm-shifting studies, if you don't mind touching base with updates in adjuvant settings with APT and ATTEMPT trial and study design and some of the key findings, please.
Yeah, absolutely. So neither of these are particularly new studies, but we did see updates from them here at San Antonio this year in 2022. If you recall, the APT trial was an attempt really at de-escalation or giving less to those patients with HER2 positive breast cancer that may not need it. And so to qualify for this trial, you had to have a less than 3 centimeter tumor and be node negative. And patients received just paclitaxel and trastuzumab for 12 weeks. So you can kind of think about it as mini HER2 treatment, if we're going to steal things like baby Tam from the session. What we saw is now we have 10 years follow-up. And with 10 years follow-up for those patients that had kind of good clinical risk features in HER2 positive breast cancer, the cure rates are still over 95%. Now, functionally, we do have new agents like TCHP and kind of bigger chemotherapy regimens. And so at least who I'm really using those for in my clinic are traditionally the 2 centimeters or less and node negative. But I think this is really, good data, reassuring now, especially with long year follow-up at 10 years. We also saw some data from ATTEMPT. And remember, ATTEMPT was the opportunity to look at adjuvant TDM1 and HER2 positive breast cancer. Similarly, now with multiple years of follow-up, we also see greater than 95% cure rates. But also remember that when ATTEMPT was reported, we actually were a little bit disappointed in tolerability. And it turns out that 1 year of TDM1, an antibody drug conjugate, might be a little bit too long. And so there is another trial led by Dr. Tolaney looking at ATTEMPT 2.0 of whether 6 months might be enough. So stay tuned on that.
Well, we continue to see the pattern that more is not always better. Now, focusing on one particular agent here, trastuzumab deruxtecan. At this conference, we saw updated data on DESTINY-Breast02, DESTINY-Breast03, and DESTINY-Breast04. Can you please start off with DESTINY-Breast02 and 03 study design and its key findings?
Yeah, absolutely. So DESTINY-Breast02 was kind of a so-called third line and beyond trial that looked at trastuzumab deruxtecan. I think everyone's familiar with this HER2 antibody drug conjugate at this point, versus treatment of physician's choice. And so we saw data that for progression-free survival as well as overall survival, we had about a year improvement on both. So certainly significant. I think the only kind of popping of our bubble in terms of that study is actually DESTINY-Breast03. And DESTINY-Breast03 was a second-line study looking at trastuzumab deruxtecan versus TDM1. And this has been presented multiple times before. But what we saw this time was overall survival data. So not only is progression-free survival improved by about 22 months, or almost 2 years for patients that received trastuzumab deruxtecan over TDM1, although the medians weren't reached, overall survival was actually quite significant as well. And so that's really encouraging. It had a hazard ratio of 0.64. And so functionally, I think most patients in the clinic are probably going to receive trastuzumab deruxtecan second line. And so that's why I said, unfortunately, it makes DESTINY-Breast02 a little bit less clinically significant. One caveat of some patients that may receive something else might be somebody that has very active brain mets and could receive tucatinib per the indication. But I really think, we're continuing to see trastuzumab deruxtecan go earlier and earlier. And as we all know, there's trials pending in the first line metastatic setting, as well as neoadjuvant and adjuvant for trastuzumab deruxtecan.
Thank you, Dr. Hamilton. As you've said, this just solidifies our second-line treatment. TDXT is approved in this setting. And based on this data, we also know that TDXT works after TDM1. But given the approval, given the data, we'll be using TDXD in second line and then TDM1. But we don't have any data on that. What are your thoughts? How would you sequence that?
Yeah, I think you've identified, a key kind of unknown spot in HER2 positive breast cancer. I think most of us, as you say, are using trastuzumab deruxtecan second line. Certainly the magnitude of the data is just astounding. I personally am using capecitabine with trastuzumab and tucatinib third line, and I'm coming back to TDM1 probably fourth line. And that's for a variety of reasons. One, I think TDM1 is clearly the inferior antibody drug conjugate at this point. So to kind of use the inferior ADC right after the better ADC just doesn't feel incredibly great. The other thing is, one proposed mechanism of resistance to trastuzumab deruxtecan is a downregulation of HER2 expression on the cell surface. So meaning those patients that have been on trastuzumab deruxtecan may not express a lot of HER2 anymore, at least temporarily. And so you could imagine that, as I like to say, naked chemo with capecitabine in combination with trastuzumab and tucatinib may be a better choice. And then coming back to TDM1, a little bit with spatial separation from our trastuzumab deruxtecan.
I think sequencing is certainly going to be the key here. Dr. Hamilton.
Absolutely.
We are seeing some ILD, which has been certainly a concern. When TDXD is utilized in earlier lines, we see less of those incidents. Do you think that it is because we are getting better in identifying and managing ILD, or could there be another explanation to this?
Yeah, I think it's certainly that we're getting better and managing it better. In Destiny Breast 01, the first trial with trastuzumab deruxtecan, unfortunately we saw, quite a few cases of fatal ILD or pneumonitis. Overall, pneumonitis rates were about 15%. And now, if you look at the Destiny Breast 03 data, although overall ILD is still kind of in that low teens range, we no longer have any cases of grade 4 or grade 5 ILD. Now in Destiny Breast 02, we kind of did see just a tad. So, I think part of it is that it's just those fatal cases are becoming exceedingly rare. And what we've done since Destiny Breast 01 is a lot of educational about how to handle it, about being aware that it can happen. And so unlike immunotherapy or other drugs that can cause ILD, where you may not really do much until you see grade 3, we know that early recognition of ILD pneumonitis with trastuzumab deruxtecan is really important. And so, we're not spacing out our scans too much. I continue to scan my patients on trastuzumab deruxtecan every 9 weeks because we really want to catch these cases of ILD when they're asymptomatic, grade 1. We can kind of get rid of the ILD, whole drug, and get patients back on the drug. The recommendation for grade 2 or greater ILD is stopping the drug, and you can't continue. Now, I think a lot of us in clinical practice do have questions about the more mild grade 2 cases and could we continue? And I think we're going to try to gather that data, but really recognizing and catching ILD when it's mild enables us to go back on therapy and prevent these more, challenging cases of ILD and poor outcomes.
Dr. Hamilton, you've mentioned that you do scans every 9 weeks in your clinical practice, but most of these Destiny trials had scans every 6 weeks. And in the community, we're often used to doing scans every 12 weeks. So there is some of this paradigm shift that a lot of us are going 9 to 10 weeks, usually after 8 weeks, because that is what insurance would allow. But I really think closer scans in the community is very important.
That's exactly the issue. Realistically, we can't get scans every 6 weeks. No insurance company is going to pay for that. Typically, we can get scans, after that 2-month point. And so 9 weeks works out very well. But, I agree, it's typically these treatments that patients might remain on for a long time, CDK4/6 inhibitors, trastuzumab deruxtecan, where there's a desire to space out the scans just because they're burdensome on the patient. And obviously there's a cost issue there as well. But I think with trastuzumab deruxtecan, really taking a close look at these scans are too important to space them out much beyond 9 weeks.
Couldn't agree more. Dr. Hamilton, TDXD got approved in low HER2 patient population based on Destiny Breast 04. We also know that there's significant discordance in patients being labeled as low versus HER2 negative. What are your thoughts and some takeaways from the updates of Destiny Breast 04 and HER2 IHC? Is it truly the right test for these patients?
Yeah, absolutely. So, Destiny Breast 04 was a trial that created a paradigm shift for us. Historically, you were either HER2 positive or you had cancer that was HER2 negative. There was no concept of HER2 low, right? And so, it wasn't that it hadn't been looked at. We looked at trastuzumab in those patients that were HER2 low. It was stone cold negative. But with these new drugs and new mechanisms of actions, bystander effect, it's really kind of changed the game here. And so Destiny Breast 04 was a trial that looked at trastuzumab deruxtecan versus treatment of physician's choice, essentially chemotherapy, for patients that had HER2 low expression, 1+ or 2+ and IHC negative. And really, Trust clearly outperformed chemotherapy. And so this is a new standard now. I think the question you raise is exactly the right question, is that HER2 low is pretty imprecise. And in reality, IHC was designed to pick out patients that had high expression. It was never designed to pick out the difference between a 0 and a 1+. And in reality, I don't really even know that you need 1+ to have activity. For example, in the DAISY trial, we've been seeing about a 30% response rate, even in patients that have IHC 0. Now, the question is, does 0 mean 0? And no, it doesn't. You can actually have thousands of copies of HER2 on the cell surface and still be classified as a 0. And so in the session at San Antonio this week, there was a fantastic analogy that you don't weigh a mouse on a scale built for an elephant. And so we're in the situation now that we're trying to look at mouse-like amounts of HER2. And so is there a more quantifiable way that we can really get at that and figure out what's the most appropriate threshold? So how do I handle this in the clinic? Well, first, I repeat the HER2, because if you're looking at a pathology report that was read by a pathologist 2 years ago, they didn't really care between a 0 and a 1+. It wasn't actionable. It was going to be HER2 negative either way. And so they weren't necessarily spending a lot of time really trying to figure out whether there was any area in that tumor that had 1+ expression. And if there isn't historical material, very appropriate to rebiopsy. I've also had a lot of people ask, well, what about if the last result maybe was negative, but they've had HER2 positivity in the past? And I think this gets into tumor heterogeneity, where even within the same lesion, you can look at one spot and maybe there's HER2 low expression, and another spot there's not. And certainly if you go and look at other metastatic sites, we see this. So really, I think probably all of us are being a little bit liberal on this, that we're really just trying to find a spot that had some HER2 low and kind of considering that actionable.
And HER2 0 was actually defined if you're less than 10%. So there's so much room and subjectivity in this.
Absolutely.
Dr. Hamilton, coming back to DB04, this is the same patient population, triple negative, hormone receptor positive, that will be exposed to immunotherapy and mTOR inhibitors before getting TDXD. If a patient has had pneumonitis, but now has resolved from immunotherapy or mTOR inhibitor, how would you tackle TDXD in that setting?
Yeah, that's a great question. And it's information we really don't have from the clinical trials, because really patients on clinical trials had not had pneumonitis ILD. I think functionally they're different classes of molecules. If somebody's completely recovered from the pneumonitis, it's hard to say that you're not going to offer somebody a therapy that so clearly improves outcome when they're living with something like metastatic disease that is going to shorten their life. And so I probably would offer those patients and just keep really close eye. I think another big thing that doesn't get talked about enough is patient education. Really, hey, if you have that cough, if you're short of breath going up the stairs, don't think that you're out of shape or you caught a virus. I want to know about it and I want to look into it. And so I think our patients can really help us kind of, sound the alarm if they're having any, pulmonary complaints, and help us monitor as well.
I think as a community, as well as patient education and training ourselves for these side effects is going to be the key with all this. Getting comfortable with these antibody drug conjugates is so much more important now than ever before. So thank you so much for taking the time to review these practice reinforcing studies and updates from San Antonio Breast Cancer Symposium, Dr. Hamilton. We truly appreciate your time.
Thank you so much for having me.